The second lecture we're going to cover today is alternative airway management tools. Now, I use the word alternative, not backup, because sometimes your backup might be your plan A. Let's remind ourselves about the quadruple setup. This is essentially each of the tools that we're going to dissect and take a deep dive in today. Intubation, we'll cover both direct and video laryngoscopy. We'll talk about optimal bag valve mask techniques, extraglottic devices, and lastly, surgical airway. So let's look at the airway through a lens of the first attempt didn't work and we need to try again. So don't just do something different, do something smart. How do we need to change our technique or our plan to be successful on the second try? So if I've had a failed airway, remember you have to ask yourself, is this a failure to intubate and a failure to oxygenate? If that's the case, we're going to our crash airway algorithm, which is bag better, and move to crike with a supraglottic as a bridge. Let's talk about the failed intubation attempt. That's not a failed airway. We're actually able to oxygenate our patient, and we have some time to think about how we can improve our techniques. So first, assess how you're doing with oxygenation and what did you see? Were you able to see the epiglottis, or did you see nothing but tongue? Are you able to get the SATs over 93%, or is this the patient who desats as soon as you put the blade in the mouth? If the answer to those is yes, then this may be a patient I need to change my technique on altogether. So if I have a patient that I can't intubate and I'm not able to get their SATs up and I saw no structures, maybe I change my device. This might be a time to put a supraglottic in and head to the hospital. But if the failure was something else, let's talk about how we can change our technique to get success the second time around. So identify the cause of the failure. It's usually two things. Either I couldn't see the cords or I couldn't pass the tube. We'll talk about video and direct and how each of them have their challenge with these. But regardless of what tool we use, we're going to tailor our skill to get it the second time. So if the problem was that I couldn't see the cords, ask yourself, are they in the best ear to sternal notch sniffing position? Did I use dynamic techniques to help position the airway as I intubated? Was the patient fully paralyzed so that I was able to have optimal view of the cords? Could I identify any anatomy if I wasn't able to see the cords? Maybe I could see the arytenoids. Maybe I could see the epiglottis. Was it excessive secretions? Did I have a large tip suction aiding my intubation, or was I overwhelmed with emesis? And did I pick the best blade and the best type of blade? So VL versus DL, curved blades versus straight blades. Now, if I was able to see the airway, but I couldn't pass the tube, honestly, this is usually a problem that people come across when they're using video laryngoscopy and they haven't had a lot of experience with it yet. So ask yourself, did you use a bougie? Did the ET tube obscure the view? How was your stylet? Was it the proper angle for the type of blade that you're using? Were you getting caught up on any structures? And what tube size did you have? Maybe it's too small and you have laryngeal swelling. The easy fix for that is getting a smaller tube the next time around. What grade was the view? So maybe you had a partial view that you can now improve, and then you'll be able to pass the tube the next time. So if at first you don't succeed, try something else, try something different. Optimize the second attempt. Now I say make this your last attempt, but I don't say this in absolutes. We're going to talk about some complications here shortly with each attempt. So if I can't get an intubation on the second attempt, I better have a really good reason to risk a third attempt on a patient who a backup device could have worked on. So learn from your experience. With the person who tried the first time, be the person who tries the second time. So they're a veteran of that airway. Let them change their tactics and adapt. Caveat to this would be a really physiologic difficult airway and a new trainee, a new medic student. You don't want to put the patient in danger. So alternative options. So make sure that you get a nice two-hand thumbs up technique to reoxygenate the patient. Get their SATs up. Take your time here. Slow, gentle bagging, and ensure the medications are still lasting. If I gave some short-acting medications, I may need to redose my medications or change the medications I'm using. Consider a blade change, VL versus DL. The difference between these is often Has much to do with the operator, which we'll talk about soon. Uh, does an SGA work as a backup? And do I need to perform a cricothyrotomy? Remember, if I have a failure to intubate, but I can still oxygenate with other techniques, I don't need to perform a cric. So here's why the attempts matter. Even one attempt at intubation has about a 15% rate of some sort of complication in the emergent intubation setting. More likely than anything else, it's hypoxia. Notice 10% up to all the way up to almost 60%. Esophageal intubations are coming shortly after, and then aspiration coming after that. Things like cardiac arrest and severe hypotension are fortunately more rare. But notice the blue line here. Overall, one attempt at 15%, but even a second attempt is almost 50% complication rate, and then it goes up significantly with each continued attempt. This is really the groundbreaking study that told us, hey, the number of times we try to intubate people matters. Let's try to set ourselves up to get it on the first attempt. And I better have something I can change that will make me think I'm going to be successful on the second attempt if I'm not going to go straight to a backup device. Positioning. By far and away, proper positioning is the most important thing to set you up for success. So we're going to think about success. We're going to think about the position of the provider. So you, the patient, are they on the floor or can I move into a gurney? Some dynamic positioning techniques we'll talk about, and this is positioning that happens during the intubation attempt. An effort between you and your airway partner that helps manipulate the airway to have success on the first try. So let's start with your position. Ideally, put the patient on a gurney. Unless I'm forced to act or it's a cardiac arrest situation, get the patient on a gurney so you can oxygenate them, resuscitate them, and get yourself in the best position. So what you want to do is have the patient's head to about the level of your sternal notch. You want to grip the blade low and basically stand back so you align your eyes with the axis and keep your elbow in tight. As you're lifting here, you want the blade to be less than 45 degrees. So sweeping into the mouth, lifting up and away, elbow in nice and tight, so that you're lifting and extending those tissues. The idea is that I want to create this direct line of sight. I want to displace the jaw and the tongue so that when I stand back, I can look straight down through that mouth and see the glottic opening. Often we start patients in a sniffing position. Think about the sniffing position as your starting point. I want to align the ear to the sternal notch, but I want to also consider positioning that I may need to do during the intubation. This gives you a little bit of an idea of what's going on in the airway as you're manipulating the head. Hyperextension actually makes the airway much more anterior. So notice the curve here. This person has a nasal tube going in. But you can imagine, like, when you hyperextend the head, so if you pad behind the shoulders on an adult or put them in an occiput off position without adjusting the head, then your ET tube has to make around a really sharp corner to get that really anterior airway. Now, a patient who's laying neutral will also have an anterior airway, but definitely better than hyperextended. And then lastly, that head forward sniffing position not only makes the alignment of the airway to the opening of the mouth more straight, it actually creates space in the oral pharynx. So you have a greater line of sight and a larger visual field. So flex extension is another way to look at a sniffing position. So I'm flexing the lower cervical spine forward, and then I'm extending at the base of the head to get that ear to sternal notch alignment. Plane of the face is parallel to the ceiling, and I have a nice open neck on the anterior surface. So what we don't want to do is intubate people flat if we can help it. We don't want them down low on the gurney where we sort of have to chase them. So pull them up all the way to the top and let the head just kind of pop off the back to start with. At this point, elevate the gurney about 25 to 45 degrees, but you'll know it's the right elevation when you elevate it to the level of your xiphoid. What this does is it can improve your glottic view if I lift the head, as we'll talk about next, and it can improve ventilation and oxygenation, but because of improving pulmonary dynamics. It also may reduce our risk of aspiration, as now we have gravity working for us and not against us. So again, don't stop with just occiput off, but elevate the head. This is the point in which I'd slide a towel roll right under that head. You can see in this picture we have this great ear to sternal notch alignment. And we're talking about the ear hole, or the external auditory meatus, if you want to get nerdy with it. So once I have the patient in a nice flex extension position, I have the gurney pulled up to the level of my xiphoid, I'm improving pre-oxygenation. I want to make sure that when it's time to walk down the airway, that I'm in optimized positioning as I go. Now to do this, I can further lift the head up. I can have my partner do a jaw thrust or assist me with external laryngeal manipulation. Let's look at each of these. So the head lift essentially means as I'm walking down the airway performing laryngoscopy, in addition to my towel roll, I can slide my hand or my partner's hand under the head and lift up as I go to improve my view. The other thing you can do to improve your view is have the partner reach up from below the patient and perform a nice strong jaw thrust. This will create a better straight line of sight by displacing the jaw, and it will bring that airway more into view. Here's a video that looks at what we're seeing when we lift the occiput up further versus laying the occiput flat. So a nice head lift can really improve our laryngeal opening. This is a great technique and a great way to practice airway management, is to have a partner or your own hand lifting the patient's head as you're walking down the airway. Another thing that we can do, especially in patients where we can't lift their head because of spinal immobilization, is external laryngeal manipulation. Now, this is a little different from the burp maneuver or the Sellex maneuver that you've learned about in the past. Because really what we're doing is, as we're performing laryngoscopy, as we're walking down the airway with our left hand with the laryngoscope, our right hand is going to go on top of our partner's hand and manipulate the airway into view. So instead of someone blindly pushing pressure on the airway, you push their hand in the right position and say, hold it right there while you intubate. So that's external laryngeal manipulation. So no one should intubate alone. This is a very complex skill that needs multiple team members. So assign an airway assistant. You have a buddy to help you manipulate the head. Maybe you have someone to help hand you your suction or your ET tube or other devices that you need. You have someone watching the monitor. Say, let me know when the SATs hit 93. Let me know again when they hit 90. This stops a person from counting down from 99 and keeps a more quiet atmosphere for everyone to do their job. And then assign someone to be your pharmacist and push your medications if you have two medics. Now, once we have people positioned properly, we've done our airway assessment, we're choosing the right tool for the job. So let's talk about the bougie. So for many years, we were taught that the bougie was a last-ditch effort to help rescue an airway that we were failing at. But I'm here to tell you, this is not your grandma's airway rescue device. This actually can be a great first-line tool to increase first-pass success. So this beam trial was one of a couple of trials that looked at bougie with Mac blade and stylet, ET tube stylet with Mac blade. So of note, they were using a standard geometry Mac blade, but it was on a video laryngoscope, so keep that in mind. Their primary outcome was first pass success in patients with at least one difficult airway characteristic. So one of those alphabet soups. And they found a huge difference, right? 96% first pass with the bougie and 82 with stylet. Huge difference for these difficult airways. But maybe something that we didn't expect was that with all airways, patients who we didn't predict to be difficult, we were getting around 87% first pass, which is kind of what we've seen in other studies with ER physicians. But once they added a bougie, they were up to 98% first pass success. And in using the bougie, it didn't take longer statistically, and there wasn't higher rates of hypoxia. Now, keep in mind, this study is done at what I would call a bougie center of excellence. So, a lot of these people intubating are residents who have been intubating with the bougies for a long time. So, this doesn't tell me that I can just hand a medic who never uses a bougie, and they'll get 98% first pass success. But this does tell me if I use a bougie regularly and that I have this seamless muscle memory with myself and my crew of using a bougie every time, that it's very likely I can get these great first pass success rates. So for people who aren't sold on using the bougie for everyone, let's talk about a breakdown of patients that there was a really big difference on. So anyone in cervical spine immobilization, in this study, they had 100% first pass success versus 80, almost 80, 78%. Obese patients, 96% versus 75%. And then any patient with an incomplete glottic view. So think about those Cormack-Lehane grades that we talked about earlier. 97 versus 60%. Now, this one makes a lot of sense to me because the bougie is small. The diameter of the bougie doesn't obstruct your view when you have a partial view. And again, there was no difference in time to intubation or any of the complication rates between the group. So what makes the bougie such a wonder? One, it's small. It's much smaller than the end of an ET tube, especially with that balloon that often obstructs your view. So that small diameter doesn't obstruct your view. The coude tip or the upturned tip is wonderful for intubating patients if I only see the epiglottis. If I can guide the coude tip up and around the epiglottis, I'm pretty sure it's going to go right into the trachea. And good news is I should get some tactile feedback that it's in the right place, even if I didn't see it go through the cords. As that coude tip taps along the tracheal rings, I will feel the reverberation down the bougie. We call this rumble strips. And the bougie is meant to keep extending all the way down till it stops. This is called hold up. When the bougie is at hold up, I have gone past the carina in the probably the right main stem bronchi, and I've hit resistance. These two things tell me that I am in the airway, not the gut. There's a few ways that we can hold our bougie. We can use a standard pencil grip, or we can use what's called a shaka grip. We'll talk about these two things in the breakout sessions and give practice. So standard classic bougie is I perform laryngoscopy, I get the best view that I can, I insert the bougie as I would an ET tube, but I keep the laryngoscope in place. At this time, my partner or myself can feed the tube over the bougie, extend the tube, railroad it right over the bougie, and as you pass through the cords, or just before you get to those arytenoid cartilages, start to rotate the tube a little bit to the left, and this leftward rotation helps avoid the bougie getting cut on the arytenoid cartilages. Another way that you can do it is by preloading. So preloading with a Kiwi D grip is one that people like. Um, we'll practice this in the breakout sessions because some people love this and some people it doesn't work as well for. Well, the benefit is that you don't need a partner to help you with the bougie if you have it preloaded in this fashion. Sort of the downside is you don't have enough bougie in front of you to necessarily feel hold up, and you may not feel the tracheal rings through the ET tube. Pencil grip preload is another way to do it, but we need to be really careful that we pinch the tube nice and firmly so that the bougie doesn't slide backwards through the pencil grip. But both of the preloads make this a little easier to do if you don't have a partner who's very experienced. But they do both have sort of ups and downs for them. So again, this is what I'm talking about. If often when we insert the tube over the bougie, the bevel is facing downward, so it wants to catch on those arytenoidal rings. So a workaround, like shown in this picture, is you pull back a little bit, and you rotate left, and then you extend it down the vocal cords. Now, I would argue just turn it to the left every time that you put the tube over the bougie to make sure that we don't come into this problem. So a slight rotation to the left right as you're passing through the cords. Let's talk about the next really important airway technique, but bag valve mask. So when bagging fails, how do we bag better? Or better yet, how do we bag awesome from the start so that it doesn't fail? Of all the airway techniques we'll talk about today, this tool that oxygenates and ventilates is the most important. This is what will save lives much more often than a laryngoscope and an ET tube. So BVM, classically you were taught this C and E grip, which was kind of problematic, right? It's very hard to get a good seal. It's sort of air leaking out on the sides. So then they said, well, if that doesn't work, if you have enough people, do a C and E grip still, but do it with two hands. Now we're teaching the thumbs up technique. Why this is the best is because what it frees up is all 8 of your fingers to get under the jaw and pull the jaw up into the mask. What we want to do is pull the jaw into the mask, not necessarily shove the mask down onto the face. With my 2 thumbs up resting on both sides, I have nice equal pressure of the mask over the face, and I have all these fingers free to give a nice jaw thrust. Now, many people say, we just don't have the people power for this. We only have one person to bag a patient. And I will argue, unless chest compressions are being done, if bagging isn't going well, nothing else on a scene matters. The only thing more important than oxygenating and ventilating my patient is performing chest compressions. Once you know you're oxygenating and ventilating, now you can move on to other tasks on the scene. So remember, pull the mask up and in, pull the jaw up and into the mask. Don't push down on the mask into the face. Now, if you're bagging someone and you still are having a hard time, you can pad under the head, get them in that sniffing position. That can improve your airway dynamics. Don't forget to use an OPA because the biggest failure of a BVM is lack of using an OPA. If those things are optimized, then you can rotate the head a little bit. So keeping that nice jaw thrust, rotate the head over to the left, then maybe try rotating it to the right. It doesn't matter which side you try first. The idea is this can actually displace some of those redundant tissues that may be obscuring the airway. So if you can't bag, make sure you bag better. Optimize the technique that you're doing. Let's sum this up. Redo your jaw thrust. Get above the patient for the best force and positioning. When you put the mask on the face, make sure you rock it open, you roll it onto the face and stretch the cuff, and then pull the jaw up into the mask. If you can, get the patient sitting upright a little bit. This can improve pulmonary dynamics. So if someone's on your gurney, all the better. BVM is a difficult skill and you may need an experienced provider. If I'm in a room with a patient with low oxygen saturation who's being bagged, I go straight to the head and I hold the mask. And you can run the scene from the mask, but the mask seal is the most sort of difficult skill. Once you have ensured adequate oxygenation and ventilation, you can pass that job off to someone else, coach them, and make sure that they're continuing to do it well. And remember, the most common error is forgetting to put in an OPA or an NPA. Don't forget, you can use an OPA, you can use 1 or 2 NPAs additionally. Moving on, let's talk about our supraglottic airways. Supraglottic airways have come a great distance in the last couple of decades and have become really great rescue tools, and some might even argue primary tools for some of the patients. So let's talk about the tips and the pearls to using supraglottic airways. They do have some limitations. Patients with airway swelling, patients with an active obstruction, and patients with high airway pressures may be patients that a supraglottic won't be ideal for. Now, this is not to say if I'm a failed airway algorithm that I can't grab for this tool. Absolutely do grab for these tools in a failed algorithm. But remember, as you're risk stratifying a patient, these are some of the limitations for this device. The iGel is by far and away the most popular in our region. This is a second generation supraglottic. All that means is it gives you a gastric tube so that when you insert the device, you can actually put a gastric tube down that gastric channel and you can decompress the stomach. So if someone has been bagging a patient for a long time before you put the supraglottic in, or if the patient has some active emesis come up the tube, pull the device, suction the airway, but when you replace the device, get that suction tube down. Keep in mind, most manufacturers don't have the right size OG tube for the device you have. So as you're doing your rig checks, take a look at your eye gels and what size OG tubes each of them need, and see if you have them on hand, because in a pinch, you don't want to have to be searching for these. Now, these devices by the manufacturer's guideline are weight-based. There's an OR study that said, actually, we can just do gender-based. And let's face it, that's a lot easier than guessing their weight. So most women are a size 4 eye gel. Most men are a size 5. And arguably, most of our mannequins, a size 3 works just great. But we're not intubating mannequins out in the real world. So a quick tool is just quick gender-based. A 4 or a 5 will work for most adults. If I'm using these on children, I'm using my length-based resuscitation tape or app or cards. Rapid sequence airway we talked about a little bit earlier, but this is something that you might keep an eye out for. If I have a patient who's in a confined space or maybe trapped in a car and they're still awake enough that I can't just put an eye gel in them, maybe they have a gag reflex, but they're not controlling their airway, and I don't want to intubate them in some awkward position and fail. Rapid sequence airway may be a great alternative. So in this case, I give the medications to sedate the patient and maybe even paralyze them. And then I put in the supraglottic. It's quick, it's easy. I'll help control the airway until we can get them out of this confined space. And once they're out and safe in your rig, you can choose if it's time to intubate them if you need to or not. Now, there's not a lot of evidence on this, but it's starting to grow. We'll talk about it a little bit more when we talk about trauma patients. So, troubleshooting the supraglottic. So, once you have this device placed, your sort of first confirmation is you squeeze the bag and you have chest rise. Generally, that tells you it's in the right place. But we're also going to want to get end tidal CO2, just like we do with ET tubes. Make sure the patient is oxygenating, and the general sort of look of the patient should be improving. Now, as you're troubleshooting, you may have a patient when you can ventilate them. You have chest rise, you have end tidal, but the SATs just aren't coming up. If this is the case, you have to ask yourself, is the problem intrinsic to the patient or is it intrinsic to the device? Things that are intrinsic to the patient are things like attention pneumo. An eye gel won't fix that. That person needs a needle decompression, mucus plugging, or bronchospasm. So remember, our patients who have asthma or COPD may have high airway pressures, and the eye gel doesn't have a strong enough seal to ventilate these patients. Sometimes mucus plugging or bronchospasm causing high pressures may require intubation. And then lastly, think about your device. So is the device obstructed? Was there mucus in the airway? Is there emesis? Is there food? You need to pull this device out, go in with your suction, take a look, and then you can reinsert it. And then sometimes it's as simple as the epiglottis just flops down over the outlet of the SGA. So this is called herniation of the epiglottis. The simple fix for this is slide the device out and then slide it back in. So not fully out, but kind of a half lift and reinsert it till it seats and then try to bag again. Usually this will overcome this and the epiglottis will flop right over that epiglottic rest that you see on your eye gel. So let's look at some evidence, and we're talking about supraglottics versus ET tubes. There's been big talks of this in the last 8 years or so. So two trials that came out, one in 2018 and one in 2019. These two trials were like 15,000 pre-hospital patients. The PART trial was looking at the King airway, and the Airways 2 trial was looking at the eye gel. And what both of these out-of-hospital cardiac arrest trials found was there was no difference between intubating patients in the field or using supraglottic devices. They didn't have higher rates of aspiration or complications, and the survival with neurologic outcome was the same. So the evidence in the last few years has just been telling us the same story. So in 2024, they published a study that said actually doesn't matter about any type of oxygenation that you do in out-of-hospital cardiac arrest. You could just beg the patient if you want. And then also this year, they published a meta-analysis looking at supraglottics versus tracheal intubation. So they looked at a whole bunch of control trials, including PART and Airways 2, I believe, that just kept reinforcing the same take home. In out-of-hospital cardiac arrest, it doesn't matter if you intubate or use a supraglottic device. Focus on the things you know that matter, like high-quality CPR, early defibrillation. Otherwise, it is dealer's choice. Maybe you start with an eye gel, perform high-quality CPR, and when you get more resources and all of your cardiac arrest priorities are taken care of, maybe then you switch to a supraglottic device. Or some people may wait till they get ROSC, and arguably, some people are right to just put the IL gel in and go with it, because if it's not broke, why fix it? So thinking about these two procedures, when I'm thinking about intubating, it's more technical, it requires more positioning, and a lot of these out-of-hospital cardiac arrests show really low first pass success in 50 or 60%. Whereas a supraglottic is easy to use, variable positioning, and which has high first pass success. High fast first pass success in this case is a single insertion of the device to chest rise. And don't forget, many EMTs can do your supraglottic device placement, and that just has the paramedic free to worry about bigger priorities. The bottom line here is use your clinical judgment for the patient in front of you. If you have a patient who has active emesis or bleeding and the eye gel is not protecting their airway, that's a patient you may need to intubate. But if you have a patient that's oxygenating and ventilating fine with the device, that can be lower on your priority list. Keep an eye out for any changing guidelines on this fact. Now, reevaluate when you get ROSC. You can consider intubation at this time, but you're not wrong to leave the supraglottic in place. Say you assess this airway and you think it's going to be really difficult. The supraglottic's working, no need to add more attempts. And then you can consider exchanging your supraglottic with an ET tube using a bougie. There's some studies that show this is only successful about 60% of the time, but essentially you insert the bougie down the supraglottic, push it all the way, try to feel for tracheal rings, see if you have hold up. If you've got hold up, you're probably in the right place. Hold the supraglottic and thread the tube over. Now, I'd use the laryngoscope to help pass the tube through the cords. And of course, this is a blind technique, so be sure that you're confirming with end tidal CO2. Now, video versus direct. Let's talk about, did video kill the radio star? So in 2024, there's a couple new studies. So in the last 20 years, video laryngoscopy has been studied many times versus direct laryngoscopy. And as video was first starting to come out 20 years ago, even 10 years ago, people weren't very familiar with it. We weren't seeing big differences in the study. Now, I would argue that's changing, and here's two studies that would back that up. So 2023, here's a study for video versus direct intubation in critically ill patients. This study is an ER study, and it's a controlled trial. Interesting, this trial is called the device trial. It's interesting because it was randomized and controlled. So it was any type of video scope versus direct. There's about 700 in each category. What they found was very high first pass success and no difference in complications. So to sum that up, they had 85% first pass success in the video group and only 70 first pass success in the direct laryngoscopy group. Overall, video was almost 10 seconds faster than direct. Now, of note, most of these intubators are either ER resident physicians or ICU fellowship training physicians. So these aren't these are new intubators. These aren't very experienced people. And so what we tend to be seeing is if people are learning direct and video at the same time, they can get a lot more proficient at video a lot faster than they do with direct. And again, remember the studies we talked about earlier, like many studies are showing 20 or even 50 or sometimes 100 direct intubations to get your first pass success over 80. All of these intubators with video are well over 80%. Now, 2024 did another study, and this one actually looked at experienced providers. This is an OR study. So just keep in mind when you're looking at an OR study, things like deranged physiology are not as helpful to compare because these are planned intubations a lot of the time. So this OR study was very big and it was randomized and controlled, and they looked at 7,736 patients. Median age was 66, and this was at an academic hospital. So they were looking at attending anesthesiologists and nurse anesthetists. So they excluded any student intubation. What they did to prep for this study was they trained all these providers specifically in the glide scope. So that this is a glide scope study. And then they used a McGrath direct scope. So a little bit more sort of pragmatic than the last study, which looked at any sort of video scope. But this is a highly trained group of intubators who intubate daily. And what we saw with them was with VL, they had 98% first pass success versus 92 with direct. Now, 92 is looking pretty good with direct, but if I can get it up to closer to 98%, this is just creating potentially more safety for our patients. So again, OR study, but we're just talking about overcoming anatomy here. And so even our really skilled intubators have some room to improve with video versus direct. Now maybe you have people who aren't sold. If you have providers who are intubating regularly with direct for many years and they're very proficient, try to just add this to your skill set. It doesn't mean you necessarily have to change. If you have a new intubator, you're going to be able to build this skill set a little bit quicker. So patients that there's a lot of benefit on. So restricted spinal immobilization. Remember, the bougie was also good at this. Obesity, again, Bucci helped overcome this. And then cardiac arrest, right? It's hard to position these patients so that you have them in a nice sniffing position. So video can be really helpful in cardiac arrest. And then it gives you some space. You can back up, as long as your arm is, you can back up away from this patient to intubate them. So there's some benefits to VL and DL. And then don't forget, some of these benefits overlap. If you're using a direct laryngoscope and you're using a bougie, I think that's a reasonable option. Now, there's some things we need to consider about video because it is not the same as direct. It's a very different skill set. So as we're practicing, we really want to focus on which tools are my weakness and how can I improve them. And then you can have your go-to be the thing that you're best at. But when it comes to video, the relationship between the glottis and the ET tube has changed versus direct. The ET tube tends to get hung up on the trachea with poor technique, and the view that you think you want is not necessarily the view uh, that you should have. So let's take a minute to go through the different types of devices. Common scopes that we see out there are channeled devices and unchanneled devices. The two on the left, the King Vision, the AirTrack, are two examples of channeled devices. The McGrath and the Glide Scope are a couple of examples of unchanneled devices. Now, I have no conflicts with any of these manufacturers, so whatever device you're using, just be familiar with it. I don't have a strong feeling that one is better than the other. So a channeled device like the King Vision here does not take a regular stylet. You insert the tube into a channel. All of the talent is in positioning the blade in the right position, and then you just shoot the tube through the channel, essentially. Another one that you'll see is an AirTrack. Now, AirTrack was initially designed almost like a periscope where you had to get really close and look down, which definitely is not ideal to be that close to your patient. So they said, okay, let's put a camera on tap. So much like King Vision, the AirTrack is a channeled device. But look on these devices because a limitation of these devices is the size of ET tube you can use. So it says on the package how big the ET tube can be. So lube, 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 lube is your friend. We'll talk about the bougie in relationship to these channel devices shortly. McGrath is an unchanneled device that you may see out there. They do have one that's a little more hyperangulated, but essentially the McGrath is mostly a standard geometry blade, which means I'm going to walk down the airway, I'm going to lift like I normally do, and I'm going to get a direct view of the vocal cords. Now, I also have a little extension of this camera to get an indirect view as well. So essentially, this is direct laryngoscopy on steroids. You can use the same technique that you're used to. You can use a bougie successfully with this device, but you get an addition of an extra PEAC around the corner. Now, the glide scope is an example of a hyperangulated blade. The older version of the glide scope is the Ranger. This had a separate screen from the blade. The newer version, the glide scope Go, has the screen right on top of the blade. A big benefit to this device, along with the AirTrack and the McGrath, is it has pediatric blades. You can use a standard geometry like a macro Miller with the glide scope or the hyperangulated. I'd like to spend most of our time here talking about the hyperangulated blade and the hyperangulated stylet because these are the devices that are the most different from the direct laryngoscopy that you're used to performing. So geometry matters. So hyperangulated blades are meant to peek around the corner without displacing much tissue, whereas your direct geometry or standard geometry are meant to lift the tongue and the jaw to create a straight line of sight. So when I am using a hyperangulated video scope, I'm using very little force. I'm sliding the blade into place. I'm actually holding it with my fingertips instead of gripping it down and low like I do with direct. You can see the difference in the geometry. So I'll tell you, a sniffing position is best for direct or video, but placing someone in a flat supine position, I can actually get a pretty good view with a hyperangulated scope. But what I don't want to do is have them hyperextended. So with either of these devices, hyperextension is not helpful. So let's kind of compare and contrast the two. So in direct laryngoscopy, I want my ET tube to be straight to cuff because I have a straight line of sight. Sniffing position is very important, but even as I lift the tongue and the jaw up, I have minimal tracheal displacement. So the trachea itself stays in my straight line of sight. Whereas a video laryngoscope looks around the corner. I don't displace the jaw or the tongue much at all. I just peek around the corner. So I don't have to be in a sniffing position, but the sniffing position is still helpful. And if I over insert my blade too deeply, or if I use a lot of force on my blade, I will actually tilt the trachea more anterior. So in this picture on the right, you can see that black line is supposed to be the trachea. The deeper I go with that curved tip, the more the trachea is going to go anterior, the more difficult passing the tube will be. So here's an example. If I walk down the airway with my hyperangulated blade, I peek around the corner and slide it right into the vallecula, then I create an angle that my ET tube can pass. If I put it too deep and I get really close to the vocal cords, then not only does my tube have to overcome this elevated trachea, it also may hang up on the end of the end of the glide scope as I try to pass it. So naturally, when I have a hyperangulated ET tube, it's coming from below the glottic opening and up. So it's following the curvature of your laryngoscope. And naturally, the way the bevel faces, as you get the tube through the vocal cords, it wants to get caught on the tracheal rings. So bevel can catch on the tracheal rings, and it's what you'll see is just resistance when you're trying to get the tube to go all the way through the vocal cords. The trick for this is a slight rotation to the right. Remember when we were using the bougie, we rotated left. Well, using a video laryngoscope that's hyperangulated, just spin that tube a little to the right. This will lower the bevel and allow you to insert the tube all the way down. The other trick is that we need a 50-50 view. So the picture on the left here, you see this beautiful view. The vocal cords take up the whole screen. This will actually make it very difficult to pass the ET tube because likely the trachea has been tilted upward and I have no visual field to see where my tube is or where it is coming in on this airway. So if you get into the airway and you have this big view, back up a little. Generally, I recommend slowly walking down midline and then inserting the tip of your video scope into the vallecula. As you see on the picture on the right, the tip of that scope as it enters the vallecula, slightly rocking back your hand will actually engage the hyoepiglottic ligament. This will give me a nice 50-50 view, meaning the top half of the screen is glottic opening. The bottom half of the screen is great visual field for me to see my ET tube approach and make adjustments. So excessive depth of insertion reduces your reduces your visual field, it demands great accuracy in passing the tube, and it tilts that laryngeal axis upward, making it even more difficult to get the ET tube to go down the trachea after it's gone through the vocal cords. Now, once we've positioned our device and we have this lovely 50-50 view, the device is set it and forget it. So get a 50-50 view and then just stabilize the device. What you're now going to manipulate is the stylet. All of the talent in an unchanneled blade is with the hyperangulated stylet. So let's compare this to a standard ET tube with stylet. So standard ET tube is bent at about 30 or 35 degrees. That's the hockey stick position. And that goes in line with my direct laryngoscopy where I have a direct line of sight. With a video laryngoscope that's hyperangulated, you will need a stylet that's hyperangulated that is also bent at about 70 degrees. Now these are rigid, they are not meant to be malleable, so don't bend them. So just to kind of give you some reference here, hyperangulated stylet versus your standard hockey stick versus your bougie, these are all very different geometries. Now let's take a moment to talk about bougie. If you are using a standard geometry Mac video scope, a bougie is a great tool. You have a direct line of sight. All of the benefits of the bougie are still there. If you have a bougie though, and you're using a hyperangulated blade, that bougie does not make the bend. It will go in the gut almost every time. It's not rigid, it's hard to manipulate. Now, some people will say, okay, we'll bend your bougie right here at about 7 centimeters from the end, get it to that 70-degree bend, just like the hyperangulated stylet. The only problem here is that the bougie doesn't hold its position. So if you have any obstacles to overcome, you don't have the benefit of the hyperangulated stylet. Also, there are some manufacturers that have some malleable bougies. That's another option that may work with the hyperangulated scope. So the only time I'm using a bougie with the video scope is if it is a standard Mac geometry video scope, like the McGrath, or it's a channeled device like we see here at the King Vision. So within the channel, you can put the ET tube in the channel, loop it really good, and then you can put the bougie inside of there, but make sure the bougie extends just a little bit so that it doesn't stick out in front of the tip, but it's outside the channel. This allows you to walk down the airway, place the tip of the King Vision in the vallecula, slightly rock back, and then that coude tip will be angled right through the vocal cords as you see here. This is a really great way to utilize a video scope and a bougie. Back to the hyperangulated stylet. So there is a thumb rest because when we're performing video laryngoscopy, we're going to need to pop the top and extend the distal tip. The design is rigid. Sometimes I will put a little bit of lube between my tube and that blue top of the video scope just to make sure that it's not a tight fit. So as you're walking down the airway, your hyperangulated stylet needs to follow the direction of your hyperangulated blade. Once the tube comes into your field of vision right below the arytenoids, you're going to pull back like a slot machine. So think about holding this stylet in a thumbs up or overhand position. Rock back like a slot machine. That passes the tip of the tube through the cords, and then you're going to pop the top. So in the second picture here, this little thumb flick, what's happening is I'm softening the distal tip of the tube so that I can now rotate it to the right ever so slightly and pass it down the trachea. Then remember, when you remove the stylet, pull it down and out so that we don't displace the tube. So let's look at this in sequence. When you're walking down the airway, there's times to look down in the mouth. There's a time to look up at the screen. So look down as you insert the blade into the mouth. Remember, it's midline. It's not displacing tissues. As soon as the tip of the video scope disappears behind the tongue, look up to the screen. So look down to insert, look up to position. Once you can see the epiglottis, tiptoe your way down into the vallecula and a slight rock of the tip back onto your hand. Once you have your 50-50 view, set it and forget it. Remember, the talent from here on out is the hyperangulated stylet. So it's time to look down again as I insert the stylet. Now, come from the right side of the mouth and look in the mouth until the tip of the tube gets past those molars and it starts to go behind the angle of the tongue. Now you're going to you're going to look up to the screen. So again, look down to insert. Once it's inserted clearly, look up at the vocal cords, and then once you look up, bring the tube midline and pull back like a slot machine to advance it. So again, let's go through this procedure. Look down in the mouth, walk the laryngoscope in as it disappears behind the tongue, look up to the screen, get your 50-50 view. While you're doing that, generally insert in the vallecula and a slight rock back. Look down to insert the ET tube, and then look up to the screen to position it. Pull it back like a slot machine, pop the top with your thumb, and then rotate to the right as you extend the tube down the vocal cords. Now, potentially any airway could lead to a cricothyrotomy. So let's talk about how we should anticipate this procedure in our airway algorithm. So there will be blood, it will be a mess. So this is a tactile procedure. Your fingers are going to find the way. So you'll have some visual field before your first cut, but after that you need to plan for this being completely tactile. So consider a cricothyrotomy in every airway. As far as discuss it as part of your plan A, B, C, D, feel the landmarks, do the laryngeal handshake, and at least know that you have a kit within reach. When you have a difficult airway with a stable patient, now I might know that it's a little more likely I might need a cric. I might actually even mark the neck where I'm going to have and make sure the kit is right at the bedside ready to go. A difficult patient anatomically who's also hypoxic is the most dangerous patient. So I'm going to mark the neck. I might even prep the skin and open the kit and have it laid out ready to go so I can transition through my plans A, B, C, and D quickly if I have a crashed airway. So don't forget to do the laryngeal handshake. So you can do the top-down technique, which is what we see here in this picture. But first, they find the hyoid bone, and then from the hyoid bone, they walk down to the thyroid cartilage. Feel with the index finger as you walk down the thyroid cartilage. The first soft spot you come across is the cricothyroid membrane. Alternatively, a bottom-up technique is finding the patient's sternal notch and going 4 fingers up midline, and that'll get you pretty close to the same landmarks. Make sure you practice this on all of your patients, and as you're going through class, practice it on some of your coworkers as well. So the patient who's hypoxic and anatomically difficult, here's the idea of the double setup. You mark the landmarks, you prep the skin, the kit is opened and ready, and the scalpel is even in hand. So in this picture, they're doing an attempt from above with a high-risk patient who may fail. And then we have a supraglottic ready as a rescue, and the scalpel is out. So think of anatomically difficult and hypoxic. Think of your big trauma airways or a lot of swelling, where maybe it's worth it to give it a shot from the top, but if that fails, you're ready to pivot quickly and do a surgical airway if need be. So again, just reviewing that anatomy with sort of the skin gone, that hyoid bone to the sternal or to the thyroid notch there, that's your 2 fingers in your 3-3-2. So I think of that as my no-fly zone. So from the hyoid bone to the thyroid notch is 2 fingers. I am not going to cut in that space. Then I'll find that smooth cartilage, walk down midline till I feel the first soft spot. Now remember, anywhere below the thyroid cartilage is free game for a surgical airway. We're aiming for the cricothyroid membrane because it's the biggest area that I can get without cutting through tracheal rings. If you go a little low and you cut through a tracheal ring, no problem. You've now done not a cricothyrotomy, but you've done a tracheostomy now, and that is still a valid surgical airway. So stay away from the no-fly zone, walk down midline, or do the 4 fingers up. So the only equipment you need is a scalpel, your finger, a bougie, and a tube, generally a 6.0 ETU tube for an adult. There are many kits. I also have nothing to disclose here for any particular manufacturer, but I will say any kit that's complicated that has multiple steps is not the right kit to use. So you know how to use your finger, you use a bougie and ET tube regularly. The only unfamiliar thing will be a scalpel. So again, a scalpel, generally a 10 blade, your index finger, and a bougie. Let's look at a couple of videos that are going to talk through this procedure. Now, the previous video was on a cadaver, so there was no blood, but it gives you an idea of how fast this procedure can be. Let's take a look at this being performed on someone who's alive, just to give you an idea of bleeding. Remember, the bleeding is variable. This is actually not a lot of bleeding in this particular one, but depending on the patient's anatomy, they may actually have arteries from their thyroid going right across this membrane. So if you see red spurting blood, that may be very normal. Continue with the procedure. What I want you to notice in this video is how the non-dominant hand keeps moving off of the trachea, which allows the skin to shift, and it's kind of hard to continue finding the landmarks. Notice in the last video, they were really good about keeping the non-dominant hand stabilized towards the head. So let's take a look at this one. So great video to kind of show you anatomy and show you when a patient is breathing. And obviously they did an awesome job here because this was a successful crike. But it's a couple of things to learn here. Keeping that hand anchored, making sure that you dilate with your finger. And also, you probably don't need lube because you're going to have some physiologic lube. So the most important complication that we should worry about is the anoxic brain injury that a patient might suffer if we delay this procedure. If I'm in a can't oxygenate, can't ventilate situation, I'm going to try a single attempt at a supraglottic and then move to the neck for surgical airway. Please feel free to reach out anytime if you have questions.